There are a lot of different cardiac rhythms you will encounter in the CICU, and figuring out exactly what your patient is doing can be complicated. Thankfully, when we're standing at the bedside in the middle of the night, we don't need to know if a rhythm is atrioventricular reentrant tachycardia or permanent junctional reciprocating tachycardia. In that moment, it doesn't matter. So let's make CICU rhythms simple. There are 3 things you need to determine when you see that your patient has a change in rhythm. Number 1, does your patient have a pulse? No? Do CPR. Yes? Good. You have time to think. Number 2, is the QRS wide or narrow? This is when it's good to know what your patient's baseline QRS appearance is, because the right question isn't actually wide versus narrow, but wider than before versus the same. If it's wider, we worry about ventricular tachycardia, though this is less common in little kids compared to adults. We're more likely to see it in teenagers and children with cardiomyopathy. It could be SVT with aberrancy, but until your electrophysiology friends come and tell you differently, assume VTach and follow the Powell's tachycardia with a pulse algorithm. So if your patient has a pulse and the QRS is narrow, or the same as previous, you can move on to number 3. Is the rhythm automatic or re-entrant? We need to figure this out at the bedside in the ICU because initially we can treat all automatic tachycardias the same, and we can treat all re-entrant tachycardias the same, at least until those initial treatments fail and we have to call our EP friends for help. Every myocardial cell in the heart is capable of generating an electrical signal which can spread to the rest of the heart and generate a beat. Normally, the SA node, high in the right atrium, has the fastest set point and will control the rate of the heart, resulting in sinus rhythm and suppression of electrical signal generation from the other cells. If the SA node suddenly stops working, or there's heart block, another part of the heart will take over, just at a slower rate. Other areas in the heart can also speed up, overtaking the SA node and causing the heart to beat faster. This is an automatic tachycardia, one place in the heart that is beating quicker than the normal heart pacemaker would. This signal can come from the atrium, AV node, or even the ventricle. The second category of tachycardias, reentrant tachycardias, don't come from a single area of the heart, but instead result from a circuit of electricity within the heart. With every completion of the circuit, you can get a beat, which can be incredibly fast. The circuit can be contained within the atrium, the ventricle, the AV node, or even between the atrium and the ventricle, which is classic SVT. So if my patient has a tachyarrhythmia, how do I decide if it is automatic or reentrant? In general, all automatic tachycardias behave the same, and all reentrant tachycardias behave the same. First, how did it start? Automatic tachycardias rev up. The patient may first be in sinus rhythm, and then the automatic focus overtakes and then continues to increase, as the focus does not have a set rate. It may be subtle enough that the arrhythmia is missed at first, and the rate may not be much higher than the sinus rate. This is a graph of heart rate over time for a patient that goes into an automatic tachycardia. At the beginning of the graph, they are in sinus, and the transition from sinus to tachycardia is not evident. The rev up can take hours or be less than a minute, but it will exist. Reentrant tachycardias are different, either on or off. The patient is happy in sinus rhythm, then boom, the patient is tachycardic. Here is a graph of heart rate over time during the start of a reentrant tachycardia. The difference should be obvious. The same tends to go for how the rhythm stops, a slow decrease for automatic tachycardias versus a sudden stop for reentrant. Difference number 2, rate variability while in the rhythm. The rate of an automatic tachycardia varies based on what is happening to the patient. These tachycardias are affected by temperature, agitation, and intrinsic and extrinsic catecholamines. So if your patient is on a high dose of epinephrine or has a fever, the rate will be higher. Reentrant tachycardias have a set rate. Crying, sleeping, eating, the rate stays nearly the same. Reentrant tachycardias also tend to be faster. So now that we have identified whether a tachycardia is automatic or reentrant, we need to treat it, because even if the patient is currently stable, letting it continue will eventually cause a problem, such as low cardiac output or ventricular failure. When first starting treatment, all automatic tachyarrhythmias can be treated the same, and all reentrant tachycardias can be treated the same. Let's start with automatic rhythms. I've mentioned things that can make these go faster. We can use that knowledge to make the rhythms slower. If the patient is febrile, get their temperature down. If they're agitated, get them calmed. On epinephrine, try turning it down if you can. This may be enough to lower the rate of the automatic focus to below that of the sinus node, allowing sinus rhythm to return. If not, you may have to think about antiarrhythmic medications, which I'm avoiding talking about in this video because first-line therapy will depend on where you are and who your EP doctors are. Since reentrant tachyarrhythmias are minimally influenced by outside factors and aren't variable, cooling your patient off isn't going to stop these. You have to break the circuit, and there are 3 possible ways to do that in the ICU: rapid atrial pacing, cardioversion, and adenosine. Rapid atrial pacing is only feasible if you have temporary atrial pacing wires. Otherwise, you will need to use another method. Both rapid atrial pacing and cardioversion do the same thing: send electricity across the circuit. When the circuit tries to come back around, it meets depolarized tissue that can no longer propagate the rhythm, and the arrhythmia stops. Rapid atrial pacing and cardioversion do not work on automatic tachycardias because there is no circuit to break. Adenosine works by blocking the AV node, so this will only work if your reentrant circuit involves the AV node. All rhythms will briefly slow or stop with adenosine, but only a reentrant circuit within the AV node will be stopped completely with it and not immediately reoccur. There's obviously a lot more to rhythms in the CICU than this, but if you can get this difference figured out, you have a great start.